chat and give a little presentation. It's very timely in Black History Month. So I think that it would be great.
I think we actually planned that. I think. But let me just take the opportunity to do a formal introduction. Dr. Tamika Auguste is the Regional Director of the Women's Health Service Line for the Washington region of MedStar Health. She's the chairwoman of Women's and Infant Services at MedStar Washington Hospital Center and a professor of OBGYN at Georgetown. She's been in practice for 18 years. She's delivered a number of outstanding lectures. I've been privileged to be in the audience for several and invited Tamika to come speak today, and she very graciously accepted. So on the Teams call, you have probably about 2/3 of the IRB, very broad representation all across MedStar, multiple different disciplines, multiple different roles within the system, but all very happy to see you and hear your talk. So thank you for joining us.
Great, thank you so much for having me. Some of you, I've kind of given versions of this talk in different settings, so some of you may have heard parts of it. I will focus on, I think, what is most appropriate for the IRB. I've sat on a couple of IRBs, so I get it. So I just kind of want to go through it. I'm going to share my screen. And you guys tell me when you can see everything. Let's see. Aha. Can you guys see my screen yet?
Yes.
And you see that, are my slides moving?
Yes.
Okay, great. Okay, great. All right, so my title is Addressing Racism and Bias in Medicine. And so, like I said, very appropriate for Black History Month when we talk about systemic racism. I've listed there lots of places where we see systemic racism. I highlighted the ones that actually might be really important for an IRB because we're doing research on all of these topics, right? All of these topics, I know personally we are doing research on, and some of them are embedded in the discipline of just doing research, like consent. And so when you think about it and take a step back and think about where and how systemic racism is seen in maternal mortality and morbidity, I could talk about that for about 5 days worth, but that's a whole other thing. But think about breast cancer. We know there is an absolute difference in Black women and the survival and incidence and treatment rates around breast cancer. In clinical trial participation, there are disparities there based on race. HIV infection death. There are disparities. Around consent, there are disparities. So this is just a list, and it's not, to say that we're, again, I bring this up not to put the finger and say, look at us, but we have to the first step is to recognize this, and the only way that we're going to start to address this. So we have to change the culture. And so again, we're not, my professional organization of ACOG is not recreating the wheel. OBGYN itself is not recreating the wheel. All of our professional organizations are looking at this, oftentimes having a commitment to equity, inclusive excellence, diversity, combating racism, promoting public policy, and doing this nationwide, not just in our local area and what we're doing. There are different work groups that are being made. Like this is the one from ACOG, the American College of Obstetricians and Gynecologists. We've seen a lot of solidarity messaging coming from different organizations and groups. I'm sure if everyone looks into their own, you will see that you have the same thing. So when we are talking about bias in medicine, it's one of the first things that we have to do is agree that we got to move forward, agree that we have to build trust among each other and with our patients and the disparate groups that are there. Part of that moving forward and doing that is having self-reflection, is being very honest with yourself. And you don't have to be honest in an open setting like this. Take some personal time, some quiet time, and be really honest about where you land on the spectrum of being an anti-racist. And I'm going to talk about that in a minute. Organizational reflection. Here, at MedStar and at Georgetown, where where do we lie as an organization around being an anti-racist, particularly women's health, because it's close and dear to my heart, but building awareness, acknowledging the history, that is always a first step, and recognizing and honoring those who suffered. And then most importantly is learning, always listening, educating, and addressing the issues. This is I think my favorite diagram. It's about becoming an anti-racist. And there are different zones on becoming an anti-racist. There's a fear zone, a learning zone, and a growth zone. And I will bring this up again at the end, but I want you all to take a look at it and tell me, where do we land on this? Where do you land on this? Do you deny that racism is a problem? Do you avoid hard questions? Do you educate yourself about race and structural racism? Do you sit with your own discomfort? And again, this is all rhetorical right now. You don't have, no one has to say anything out loud, but I want you to look at this and say, where do you land on this, the different zones of becoming an anti-racist? And I say becoming an anti-racist because it's not enough to say, I'm not racist. We have to be at a point where we are anti-racist. And I think there's a difference there, and it's a big difference, and it's sometimes hard to get there, but this is what I share with you guys. So I'm going to just talk a little bit about OBGYN, because that's my specialty's racist history. I'm sure many of you may have heard about Lucy, Betsy, and Anarcha, 3 enslaved women that were experimented upon to create some of the procedures that we do today. And again, we talk about Lucy, Betsy, and Anarcha so that we remember them and we acknowledge what we did. I'm going to talk about Mississippi appendectomies and what that was, and the birth control pills in the women of Puerto Rico. And then many of you guys know about Henry Lax. That's been very popularized by different movies and folks. But the 3 enslaved women at the hands of, some of you may have heard of Dr. Marion Sims. He used to be called the grandfather of gynecology. We no longer do that. We still have equipment that is named after him. There's a retractor that's named after him, and there's a big swell within our specialty to not call the retractor by his name, but to call it like by Lucy. Give me the Lucy retractor, or the Anarcha retractor, as opposed to giving the Sims retractor. But just so that you kind of are aware of that. So we have those 3 enslaved women, and we are, in my specialty, constantly refer to them and talk about them, so we acknowledge them. And some may say, well, that was back in the day. That was, in a different time than it is now. Well, let's fast forward to 2016. And this is an article that was done when at the University of Virginia, where they looked at bias and pain assessment and treatment between Black and white patients. And they were asking healthcare professionals and medical students and healthcare professionals at the University of Virginia. And among lay persons, they strongly endorsed the belief that there were biological differences between Black and white people in terms of their pain response. When they sampled white medical students and residents, they endorsed the same belief. They thought that Black patients' pain were lower, and pain suffering was lower, and they made less accurate treatment recommendations. These are people that are in the healthcare profession in 2016. That is shocking. It takes my breath away to think about this is happening. So I bring this up not only to make everyone aware, but to, that argument of, oh, the slaves, that was back then, that was all different. That's not now. This is 2016. This is now, and this is happening. So we have a lot to combat against bias in medicine and racism. And so today, there are people in the healthcare profession that think there are biological differences between Black and white people and treat them differently according to those beliefs, which are completely inaccurate. Mississippi appendectomies in the 1920s through 1980s. And that time frame, when you think of 1920s and so forth, I was born in 1973. Like, this is shocking to me. So in the southern states, they used sterilization as a means of controlling the Black population. So what would happen is women would think they were going in for an appendectomy, and they'd actually be having a hysterectomy. And this was done as a means of practice for medical students. at teaching hospitals in the South as late as 1980. So a third of the sterilizations were done on girls under 18 and even as young as age 9. And these were in states, these individuals were targeted because they were Black, but they were also labeled as delinquent or unwholesome. So this is why they needed these quote unquote appendectomies, which were actually hysterectomies. As an aside, again, to not be so far removed from this, I'll share one of my former residents 2 years ago, her cousin, like second removed, had this happen to her. So it touched home, and we spoke about this because it really did happen. It didn't only happen in the Black population, it happened to Native Americans out in California. This continued to happen in the 1970s and 1980s. They received tubal ligations when they thought they were getting appendectomies. It's estimated that about 25 to 50% of Native American women were sterilized between 1970 and 1976. And I just want you guys to think about, some of us that are older than 45, this is time when we were born, we were alive. And so I think that hits home for me a lot, just to think that this was happening in my lifetime. We know the story of Henrietta Lacks. I'm not going to rehash it, but we know, that they took her cervical cells, created HeLa cells. I have to share a story with you guys. People, again, to kind of bring it home to everyone. My husband's family, born and raised in Baltimore. When we got married, they were all very happy and pleased that I'm a doctor, and that's great. And my mother-in-law said to me, who was born and raised in Baltimore, she's like, "You don't work at Hopkins, do you? They steal patients over there. They snatch you off the street." This is my mother-in-law, like right now. Like this was literally 12 years ago. She may have said this to me. But this is because of the stories like Henrietta Lacks, how this infiltrates the community. It is real. I can't stress that enough. And sure, maybe tongue in cheek, but she kind of believes it. You know what I mean? And that is very, very real. So, we have to remember what we've done so we don't repeat those errors. We have to recognize what we've done and accept it and as truth. And we have to take action. So what are some things we can do with action? So one of the things that is growing in popularity is that, especially in women's health, we are recognizing February 28th and March 1st as a confluence of two very important months, Black History Month and Women's History Month. And so like here at Washington Hospital Center, we do some very special programming and grand rounds and notification around this time, and special didactics and lectures and things like that around this time to recognize both Black History Month and Women's History Month and what has happened as those two intersect. Like I said, grand rounds, conference presentation, we listen, acknowledge our past, and we try and vow not to repeat the past. But I got to throw out to you Black maternal mortality. I don't know how great we're doing about not repeating the past. We have work to do, definitely. With Black maternal mortality, you hear, I've mentioned that for those of you that don't know, Black women in this country have 3 to 4 times higher risk of dying in childbirth than white women. And we have looked at it, we've been looking at it for years, and the one reason that comes out of it is because of racism. There's it. It's racism that these women face when they're in labor, that causes them to have 3 to 4 times higher risk of dying. To educate ourselves, we listen to scholars, but a little bit different than the traditional academics that we listen to. But we also need to listen to our advocates and our activists, some of our community organizers, right? They bring something to the table. I mean, I throw something out there. I know that most IRBs have a community member. Maybe look for a community member that is an advocate in this area or an activist. They will bring a different lens to your IRB, to your committee, and it will help to educate all of us there. There's curricula. There are things out there. I'm not recreating the wheel here. All the professional organizations probably have curricula around this, things to read, ongoing. And keep in mind, educating yourself and doing more is not a simple or a single implicit bias test to say, aha, I did it. Now I'm good. I check the box. It is ongoing. It is things to continuously to help yourself figure out where are you on that spectrum of being an anti-racist. And if you're not always to the point of growth, what do you need to do? Our states and local health organizations are really doing a lot of work. The state of Maryland has passed significant legislation. It is laws around what has to be done around maternal mortality and implicit bias for all healthcare providers that take care of women. That's not just OBGYNs, but I know it's going out to emergency medicine. It's going out to family medicine as well. And so this is coming from the state of Maryland. So there are a lot of places, a lot of states that are also having this type of education. So in action with around scholarship, research, and publications, what we do has to be very intentional, okay? We have to ethically address the needs of Black and Indigenous populations. We have to intentionally promote the work and scholarship of those that are Black and Indigenous, that are physicians, clinicians, public health professionals. We have to look at specific grants and fundings for around these disparate healthcare folks, and we have to mentor those. And this is one's I throw this out there all the time. For editorial and IRB boards, what do you look like? What do you look for when you're reviewing applications? Are you taking into consideration the bias that might be inherent to some of these studies and how that can be different? And it's important to understand that race cannot be treated as a biological factor. The American Society of Nephrology and MedStar Health have now adopted where they take out race from GFR. And there's more things like that. And for the clinicians that are there, are there any tests in your specialty that include race? There's no reason for that. OBGYN has done a great job in trying to remove some of those things. And I'm sure in almost every specialty or discipline, there's something that is associated with race, some medical formula or something that can be taken a different look at to say, is that really necessary? And we have to collaborate, support, and partner with. And again, this is outside of our regular academicians, right? Look at your public health community, your advocates, your activists. And we have to have a very concerted effort, very intentional on working towards achieving racial justice, reproductive justice, and equity in healthcare. We see reproductive justice now, regardless of where you stand on the spectrum. It is an issue right now in terms of what is going on and the rights that are being taken away from women. And so it's just a matter of being aware of that. And particularly in this setting, how are you addressing those in the IRB applications that come across? It's just something to think about. If you think about it and perhaps listen and review the IRB applications with that lens, you've done far more than we've done in the past. And so that would be a great step forward. For patients is to recognize the impact that history and racism has on our patients. In obstetrics, there's a declining utilization or acceptance of medications from certain patients because they have fear. For GYN and breast cancer treatment, there's a delay in treatment because there is fear, okay? We have to treat discrimination and racism as an evidence-based risk factor for poor health outcomes. We have to teach each other to recognize discrimination and racism when we're caring for patients. And we have to speak up. And that's being an anti-racist. And it's hard, it's not easy. I try my very best all the time. I don't succeed sometimes, I miss things. But we also have to amplify the work that our community-based organizations, advocates, and activists are doing. We have to work together. This is not just academia doing it on alone. We have to really come together. I'm happy to share these slides with you. Just some resources that for you guys to look at, videos, articles to review, and how to get to the root of different injustices. And then again, I bring this back to you guys. This diagram, I share this with leadership teams, departmental level, managers, leaders, staff, residents, students. This is for everyone. Where are you on this path of becoming an anti-racist? I think that, you take some time, really think about it. And, hopefully there's learning zone and there's growth zone. And it can change from situation to situation, and that's okay. That is really okay. Well, what's MedStar Health doing and Women's Health doing particularly? Many of you might be aware of Safe Baby, Safe Moms. It's a large grant that MedStar got, the largest grant that we've ever gotten. It came from the James and Alice Clark Foundation on reducing maternal mortality and morbidity. Like I mentioned, we received it in April 2020, $30 million. Given to MedStar Health to improve the health, welfare, and outcomes of mothers and infants in Washington, D.C., and to specifically address the social determinants of health and the racism and bias that people that women are facing. So here at MedStar, Women and Infant Services, OBGYN at Washington Hospital Center received a large chunk of that. Department of Family Medicine, Community Pediatrics, and Child and Adolescent Psychiatry at Georgetown also received a large portion of that $30 million grant. Here's the leadership of that. Dr. Evans and Neil Weissman from MHRI are very much involved in this grant because I think of the large eyes that are on this, the largest grant that we have. We have significant leadership around. And, again, we can't talk about this grant and not talk about the effect that it's having on the social determinants of health, on racism and bias. For Safe Baby, Safe Moms, they're looking at the care delivery through different stages of the life cycle, ensure delivery of competent care to diverse populations. It has allowed us to have a lot of resources on doing a lot of work around implicit bias. We are not only doing it on individual clinicians and staff, but also in our research and our evaluation, medical, infrastructure on IT, and again, addressing clinical, environmental, social, and health system risk factors. So the long-term outcome is to reduce maternal and infant mortality among women who deliver babies in Washington, D.C. Short-term, you can see our outcomes there: low birth rates, preterm birth rates, morbidity from hypertension and diabetes, C-section birth rates, and breastfeeding rates, all of which have worse outcomes in Black women, and particularly here in the District of Columbia. So this is a big deal in terms of what we're doing here in the district. The maternal mortality rate is much higher in the District of Columbia than it is in the United States. It's shocking. For a very long time, our colleagues at the Department of Health here in the District of Columbia didn't really believe these numbers. And we did a lot of fighting, a lot of advocating, and to say that the numbers there, and data speaks, and we actually showed it. We were very persistent, and they believe it now, which is great. And we have to do some work. But that was in 2018. I'll be very honest with you. We haven't moved the needle that much, despite our best efforts, especially with Safe Baby, Safe Moms. Looking at the social determinants of health, they're looking at economic stability, neighborhood and physical environment, education, food. The list goes on. You can kind of see, and we're really trying very hard to look at those outcomes that are based on those social determinants of health: mortality, morbidity, life expectancy, expenditures, health status, and any other limitations that we have. These are some great, again, resources and books. Medical Bondage by Deidre Cooper Owens is quite impressive. And I just share these with you, just if anyone wants to take the time to do a little bit of work for themselves. This is very helpful. Historical trauma of healthcare on Black Americans is real. There's fear, there's suspicion, mistrust, fewer healthcare visits. They terminate treatment sooner. They seek care later. I mean, just pick one. Let's look at the COVID pandemic. Pick one, like it's there. Look at breast cancer treatment. It's there. I mean, this is there. This is real. This could be why we said, why? This patient hasn't come in. Where have they been? Where have they been? Like, this is why they're not coming in. And so we have to go before that and talk to them and say, and change the narrative and work to make their visits with us something where we can develop trust with them. These are some references. This is just brief. I wanted, much longer. I have shorter time, but I wanted to share with you guys this, and this is just a beginning, right? Just keep that in mind. This is not the end all. Okay, you've had a discussion about it, and that's it, right? Like, I hope this fosters a lot of discussion, and so that we talk about it, and so that you, again, if I said, if you just look with that eye of bias on some of the applications, you're doing more than we have done in the past. around this issue. And that's just I throw that gauntlet out to you guys on the IRB to just think about that, how this is impact. And it's not just about race. It could be about gender. It could be about disability or ability to do certain things. So just think about, is there any bias here? Who does this disparately affect? Those are the questions to ask. I know you guys know that, but I want you guys to be, purposeful about it. I think that would be very helpful. So I'm happy to take any questions. I know it was really, really brief, but yeah, so I'm happy to come back and have a discussion too anytime. So
Tamika, that was fantastic. Thank you. Thank you so much.
sure.
I've had the privilege of hearing that. This is my fourth time, I think, and I learned something new every time. And I'll tell you just personally, I hadn't heard the Lucy Betsy Anarcha story until the first time you shared it, and I hadn't heard about HeLa cells. So I hope you recognize how much awareness you bring to many, or it could just be I'm ignorant. Well, I know I'm ignorant, but it's
it's great, and that's what it is. It's just an awareness. Let's start talking about it. Like, I know there are health professionals who are like, "You're kidding me?
Yeah,
like this really happened?" And I'm like, "Yes, it did." And like that shock. I mean, if we're in the healthcare profession and we're that shocked, our lay folks, our community, they have no idea, or they do, or they're hearing the really bad part of it. And we got to start to work on that narratives to kind of bring them around and let them know what we're doing. That UVA study really, that's hard. That is hard.
it is hard. It is hard, particularly when you consider some of the history of UVA in Charlottesville and the not so great past.
Absolutely.
Any questions, comments for Dr. Auguste?
Think about it. You guys can email me. I'm happy to do a little bit more of an expanded presentation like this. If anyone, a different group or something like that, I'm happy to do that. I always add a little something different and try and tailor it to the group. With different specialties, I'll do a little research into your specialty. Every specialty has something, and I'll find it and bring it out so that we can just talk about it and be aware. So
thank you.